My name is Amy Sullivan. I'm the chair of the Endowment Committee, and I'm happy to welcome you to our first in what will be a monthly series of AS&T paper lectures. This is a new initiative for AAAR, being supported by the Freelander Memorial Fund. With this idea, we're hoping to be able to highlight the amazing research in our community, tie our journal to other activities, and also give us an opportunity to all come together outside of the conference. So each month, a selected paper will be presented by its authors. And in addition, one of our student chapters will be hosting the lecture for us. I wanted to thank the board and the endowment committee for the support of this initiative, as well as to thank all of the following folks for all of their help in making this possible. So Jonathan Reed and the editors of AS&T, Yael Hartley from the AS&T editorial office, Shantanu Jathar from the Early Career Committee, and Jackie Wu and Corinne St. Laurent from our management company, Virtual. And so with that, I'll turn it over to our editor-in-chief of AS&T, Jonathan Reed. Okay, well, it looks like Jonathan hasn't been able to make it yet. I'll turn it over to our student chapter from Washington University to get us started. Thanks, everyone.
Thanks, Dr. Sullivan. Hi, everyone. Thanks again for finding the time to join us today. My name is Pradeep, and along with Audrey Dang, we'll be moderating today's session. We are both graduate students at the Center for Aerosol Science and Engineering, the student chapter of AAAR at Washington University in St. Louis. So today we're going to be hearing from Liqiao Li. She is a PhD candidate working for Dr. Yifang Zhu at UCLA's Fielding School of Public Health. Dr. Zhu focuses on exposure and risk assessments of ultrafine particles near roadways and indoor environments. Liqiao has been working with Dr. Zhu for the past 4 years and has a background in environmental engineering from her bachelor's and environmental health sciences from her master's. So as part of her PhD, she has been studying aerosols generated by e-cigarettes and vapes in indoor environments through both measurements and simulations. She's also studying transport of respiratory aerosols, which has been of a lot of interest in the past year, almost to the date. So today she'll be sharing her work on how various face coverings affect aerosol size and number concentrations while coughing. And we'll have about 15 to 20 minutes for questions and answers at the end. Feel free to submit your questions through the chat throughout the presentation, and we'll let you ask those questions in person in the same order. And with that, I will let Liqiao start.
Hi, everyone. So first, thanks to Pradeep for introducing me. Let me share my screen. Okay, so hello, everyone. I would like to first thank the organizers for inviting me to give this presentation. And thank you all for being here today. My name is Liqiao Li, and I usually go by Vicky. I'm a fourth-year PhD candidate in environmental health science at UCLA. So today, I'm going to talk about face coverings and their effectiveness to mitigate respiratory droplets in response to the COVID-19 pandemic. I believe most of you are familiar with face coverings during the past year. Here is a brief timeline of the guidelines change towards face masks. At the end of January 2020, last year, WHO first declared the COVID-19 a global health emergency. And later, during February and March, public health guidelines still focus on hand washing, where people believe this disease was transmitted mainly by close contact with infected people and contaminated surfaces. At that time, both WHO and CDC advised the general public not to wear face masks, and only people who show symptoms should wear. Later, until early April 2020, with more research showing that Asymptomatic and pre-symptomatic individuals may also contribute to the spreading of COVID-19, then health officials reversed their guidelines and recommended wearing a cloth mask. A week later, New Jersey became the first state mandating face masks. Since then, more and more states started to require people to wear face masks in the public spaces. We know there was a shifting guidelines and confusion about face masks among the public at that time. This was mainly because lack of evidence showing that COVID-19 is airborne transmitted back to that time. So how does the airborne transmission happen? The source of airborne transmission is the respiratory droplets, which can be generated by coughing, sneezing, talking, and even breathing. And when the droplets expelled by an infected person, the large droplets can settle on the ground or object surface. And some droplets evaporate quickly and shrink into smaller aerosols. If other people who are in close contact with this person may be infected by inhaling the virus-containing aerosols. And let's narrow down to coughing. Coughing is a common symptom of COVID-19, and particles generated by coughing are also a major route of the airborne transmission. And study found the virus-laden particles were less than 5 micrometer in the air. Let me explore a study conducted in two Wuhan hospitals during the peak outbreak last year. And researchers measured the viral RNA copies in the sampled aerosol at 3 locations, including 2 PPE removal rooms and a medical staff's office in the Wuhan hospitals. All the viruses were found in particles less than 5 micrometer in diameter. And here we can also see the peak concentrations of the viral RNA in both submicron and supermicron regions of the aerosols. And these particles can remain viable and suspended in the air even for hours, which may increase the infection risk. So to reduce the public infection risks, relevant public health measures have been implemented, such as wear face masks and keep 6 feet of physical distance. But by looking at these guidelines, people may have questions. For example, like what type of face covering should we wear? And how much protection does it actually provide? And can we reduce the physical distance when we are wearing the mask? So in today's talk, we're gonna look into these questions. Many previous studies have investigated inward protection by using face masks, which protect humans from the environment, and also the filtration efficiencies, which highly relies on the materials of the masks and the number of the layers. However, limited studies have focused on outward protection, which refers to the use of face covering to contain respiratory droplets from the source and protect the environment from humans. It should be noted that a large portion of people who get COVID-19, but they do not show any symptoms. They can also serve as a potential infection source. That's why the outward protection provided by face covering is particularly important during the pandemic. Let's look at the images that show our transport of respiratory droplets. These images were taken by a high-speed camera for speaking, coughing, and sneezing with and without face covering. We can intuitively see the difference between with and without face covering. Even a single layer of the face covering, close cover, can be better than nothing. On the other hand, we can also see the particles leaking through the mask, especially for the violent respiratory events. Although we have qualitative visualization of the leaking through face mask, but there's still lack of quantitative measures on the effectiveness of using different face coverings. Since we see aerosol leaking through face masks, we may want to know if 6 feet is a safe distance for us. We know CDC advised staying 6 feet away for both indoor and outdoor spaces. but we know there's a huge difference between outdoor and indoor. For outdoor environment, there's plenty of dilution, ventilation, and in contrast, many indoor environments can be enclosed and crowded with people. So clearly, more evidence is needed to support the physical distance guidelines, especially for the indoor environments, where people spend more than 90% of the time there. Let me summarize the current knowledge gaps. First, we haven't fully understood the effectiveness of using face coverings to reduce our transport of respiratory droplets. And second, limited data is on the particle size distribution, and also where we don't fully understand how far they can move in the indoor environment. So the scientific question we're going to address is how much our protection do face coverings provide in an indoor environment? In this study, we aim to evaluate the effectiveness of different face coverings to mitigate cough particles at 0.3, 0.9, and 1.8 meter, which is equivalent to 1, 3, and 6 feet away from the coughing source. We hypothesize cough particles can transport to 0.3, 0.9, and 1.8 meter away from the source in the indoor environment, and face coverings provide different ability to provide the outdoor protection in mitigating particles generated by coughing. Here is a schematic diagram of our experimental setting. We have a volunteer recruited sitting and facing the instruments in the laboratory room. We place the sampling instruments, APS and CPC, at 3 locations, 0.3, 0.9, and 1.8 meter away from the volunteer. You must be familiar with those instruments, but for people who are not in the aerosol field, I would like to briefly introduce. CPC is a condensation particle counter, which measures the particle number concentrations. And the APS, short for aerodynamic particle sizer, was used to measure the particle concentration at different sites, ranging from 0.5 to about 20 micrometer. And we also use a Q-track to monitor the temperature, relative humidity, and carbon dioxide in the laboratory room. And the last, we use a hot wire anemometer to estimate the peak flow rate of coughing generated by the volunteer. So in each sampling session, the volunteer was asked to cough every 30 seconds at an intensity whichever the volunteer felt comfortable with. And we measure the 1-minute background before coughing and 2 minutes during coughing, 2.5 minutes during coughing, with a total of 5 coughing events. And the data logging interval was set to 1 second for all instruments, and each sampling session was repeated for 3 times. All the experiments were conducted in a typical laboratory room with a volume of 138 cubic meter. And before each session, the background PNC was maintained less than 50 particles per cubic centimeter to avoid other confounding factors from the ambient particles. And the temperature and relative humidity were well controlled, and the air exchange rate of this room was about 2.3 per hour, calculated by the carbon dioxide concentration decay. It provided quite an amount of ventilation in the room. We tested a total of 7 conditions, including 6 different face coverings compared to no face covering. Because each sampling session was repeated for 3 times, a total of 15 coughs were generated under each face covering condition. Here are the face covering conditions we tested, including no face covering, face shield only, cloth mask, surgical mask, and their combination with face shield. Also, we tested N95 respirator and KN95 mask, which is considered equivalent to N95. There are 2 types of cloth masks. One is made of 100% cotton, and the other one is half cotton and half polyester. Both of the cloth masks were provided by the UCLA logistic team. More detailed information about these face coverings will be presented later in the table. So here comes to our results. This is a temporal profile of the particle number concentration when there was no face covering in a sampling session. So by looking at the blue spikes at 0.3 meter, we can see the particle concentration immediately increase after each cough and could even reach to 400 particles per cubic centimeter. And then it decreased back to the near background level very quickly within 2-3 seconds. And when the sampling location moved to 0.9 and 1.8 meter, the particle levels reduced to 47% and 10% respectively of what was measured at 0.3 meter. We also found that it took about 4 to 26 seconds for the particles to travel from 0.3 to 0.9 meter. Similarly, it took even longer time for particles to reach 1.8 meter. The wide time range for particles to travel can be linked to several factors. So first, like how fast the cough droplets evaporate into smaller sizes depends on the initial particle size and also the environmental factors like humidity and temperature. And second, once particles become smaller, they are dominated by diffusion movement that can be heavily influenced by the environmental airflow. And third, even though we have the same person to produce the different coughs, there could be always cough-to-cough variations. It should be noted the average peak flow rate of coughing in this study was about 20 liters per minute, which was 10 times lower than those reported in a previous clinical study where the patients were coughing at up to 200 liters per minute. That's why we need to be more cautious about our results, which may present a conservative estimate. For each face covering condition, we measure the background subtracted PNC at 0.3 meter and calculated the percentage of particle reduction, which is 1 minus the PNC without face covering relative to PNC with covering relative to PNC without face covering times 100%. This term basically provides the information on the effectiveness of our protection, meaning how effective face covering can reduce the particles generated from coughing. So let's first look at the face shield only. We see by itself, it only provides 4% particle reduction, which is not significant different from no face covering condition. And the closed masks provide way better protection, reach 77%. And after combining with face shield, the performance could be even improved to 89% protection. And the best performance was observed in surgical mask combination of face shield and surgical mask, as well as the N95 or equivalent, which all provide more than 94% particle reduction. A recent study at Virginia Tech found that our protection may not be as good as the filtration efficiency, indicating the importance of snug fit of a face mask. In other words, if there's a gap between your face and the mask, particles can easily leak through those holes, no matter how good the filtration efficiency the materials can provide. Also, the violent expiratory events such as coughing may further degrade the mask performance due to the movement and vibrations. To evaluate how far the particle from coughing can move in the indoor environment, we also compare the PNC during coughing to the background level at 3 locations. From conditions 1 to 4, there are clearly significant increase at 0.3 and 0.9 meter. Then at 1.8 meter, there's either a significant increase or a tendency towards increase. This data suggests that 6 feet physical distance may not be enough if your face covering is not good. In contrast, no significant difference were observed for surgical mask, combination of face shield and surgical mask, and N95. Based on this data, then we subtracted the background level to obtain the absolute value that are solely due to coughing at the 3 locations. Similarly, we see there's almost no difference between no face covering and face shield only at all three locations. And the closed mask and their combination with face shield provide moderate protection, which is way better than the face shield, but not as good as the higher grade face coverings. In addition to the total PNC, we have also obtained the site distribution data at 3 locations. Here, the x-axis is the particle diameter in log scale, and the y-axis is a dn d log dp, which is a size being normalized particle number concentration. For 6 face coverings, I grouped them by the particle reduction percentage. I know this slide is a little bit overwhelming. I will walk you through all the size plots. Let's first look at the cuff particles without face covering. Let me zoom into it. At 0.3 meter, we see most particles were found less than 2.5 micrometer, which is smaller than previous studies that reported cuff particles were larger than 10 micrometer. This is likely because the laboratory room which we used was quite big and well ventilated, provide a large dilution that facilitate the evaporation of large droplets, which shrink into smaller size very quickly. And then 80% of the particles can travel to 0.9 meter. At further distance, only 10% of the particles that are even smaller, less than 1.1 micrometer, could reach 1.8 meter. So for the 6 coverings, I divide them into 2 groups based on whether the particle reduction is less or greater than 90%. Let's first look at the face covering with particles less than 90%. At 0.3 meter, we can see the face shield, the green squares, cannot mitigate the particles almost at all the sizes. At the closed mask, which perform much better compared to face shield, especially for particles greater than 1 micrometer, but the closed mask is not that effective for smaller particles at submicron region. At further distance, we can see that the particles at submicron size range show elevated level at 1.8 meter, the purple circle and the green squares, which indicates the use of face shield and closed mask. In comparison, the second lines with the particle reduction greater than 90% all present a near background size distribution, which show the much better performance. So the green bands show the aerosol size range associated with high concentration of the coronavirus RNA copies, as I mentioned earlier. The bands largely overlap with the cuff particles in the submicron regions, which further indicate the importance of our protection effectiveness provided by face covering targeting the smaller aerosols. So for future studies, more study is warranted for the submicron range with the infection potential. And this study also have some limitations. First, it's only under a specific indoor condition, and there could be large interperson variabilities because like different people have different respiratory particle concentration, cell level contents, and the expelling speeds of the droplets. And also, we only measure the transport of aerosol towards one direction, which is from the face of the volunteer towards the front. So this warrants future study for investigating the transport of particles leaking from the 2 sides of the face mask at the left and right side direction. And more indoor environments should be explored with different ventilation conditions. More strategic mitigation measures for indoor environments to reduce aerosol transmission as needed. Here's the summary. So we found most cuff particles were less than 2.5 micrometer in the indoor environment. And our protection effectiveness rank from N95 respirator care 95 mask and greater than surgical mask, closed mask, and closed mask together with face shield. And the face shield by itself basically doesn't provide any protection. And the N95 and KN95 and surgical offer the excellent protection, which can substantially reduce the cough droplets within 1.8 meter. Despite there's a wide range of efficacy, all face coverings except for face shield only can serve as a simple barrier to reduce the concentration of cough particles and likely decrease the spread of COVID-19. And this is a paper we published at AST. If you are interested in the use of face masks during the pandemic and also the inward outward protection as well as the filtration efficiency, please refer to more recent studies as shown in the slides. So here's a take-home message for you. First, different face coverings can provide different ability to provide our protection. So from the least effective to the most effective, we can see for sure closed mask can help reduce the respiratory droplets. But if you have access to a higher grade face covering such as surgical mask, please do so, which will provide a better performance to protect yourself. And also for indoor environments, we know 6 feet may not be enough, especially for those enclosed and crowded spaces. So please keep at least or more than 6 feet physical distance for your own safety. So this thanks to the Administrative Vice Chancellor's Office at UCLA who provide the funding to this study. And also we thank Dr. Shen Q-He for providing the hot wire anemometer and the volunteer who participate in the experiments. Here are the reference. Thank you all for listening, and please let me know if you have any questions.
Liqiao, thanks so much. That was really great talk. So now Audrey will go through the audience questions first and get started.
Thanks, Pradeep. Yeah, so we're just going to go through the audience questions in the order that they were submitted in the chat window. So if you want to continue submitting questions, please do so. So to start out, the first question is, did the volunteers have a respiratory tract infection or was the volunteer a healthy person simulating coughs? I would expect a difference in particle production.
Oh yeah, that's a good question. I should mention earlier, we recruit a healthy male volunteer who doesn't have any respiratory disease.
Great. Next, what was the ventilation air exchange rate of the test room? And then it looks like it was answered in the chat later that it was 2.3 air changes per hour. So we'll go to the third question. What is the smallest particle diameter that could be sampled by the instruments that you used?
So if we, in terms of total particle number concentration, which you cover the most of the size range from the nanometers up to micrometers. So basically, I would say cover all the ranges. But if we only look at the size distribution measured by APS, the smallest particle size can be reached with 0.5 micrometer.
Great. From John Reeves, how did you ensure that the particular airflow in this room didn't bias the measurements?
Didn't bias. So I would say this laboratory room is pretty, we use the same room for all the experiments. That's why to reduce the variation and the inter variation between like sampling days, we try to ask the volunteer to generate all the coughs, and we conduct the 3 sampling sessions within a single day.
I have an add-on question to that. How sensitive was the measurement method to like coughing in a straight line? That makes sense. Like, could you tell if the
Um,
volunteer maybe was like if
Were you saying like when there's cough, how sensitive the instruments respond?
or how sensitive is it? Say if my head was angled a little bit, like angled up or angled down or angled to the side, how
I see.
sensitive was that?
I see what you mean. So to avoid any other confounding factors, so we ask the volunteer to sit straight and face towarding the instruments and with 0.3 meter away. And every time we make sure the volunteer had the same position.
Okay.
But I think it would be definitely interesting if the volunteer would have different gestures, different face directions that may affect the results, and which may be interesting for future study.
From Ben Comfort, does the surgical mask that was tested have an ASTM rating, and have you compared performances of surgical masks that have that rating versus surgical masks that do not?
Yes, like the surgical masks we used in this study were from 3 manufacturers. They're all as you mentioned, the ATM graded, and so during the experiments we just randomly draw the first surgical mask from the 3 manufacturers.
Okay, so so it was different surgical masks throughout.
Yeah, there
or
are
multiple manufacturers.
Yeah, but they're all certified surgical masks.
Do you know what level of ASTM? Because I think there are a few different levels.
I think that should be the highest one.
Okay, cool. Next, was the time of coughing? Was the time of the coughing event kept constant for every trial and across the test conditions? Or what was the timing of that?
Yeah, as I mentioned, there's some variation, the cough-to-cough variation. We asked the volunteer to cough just one time, but at the level he's comfortable with. So
Okay.
the time is pretty much close, similar, but it's still like we just let the volunteer to cough by himself. Yeah.
And then looking at that figure, I have a follow-up question. Is when you calculated the reductions, were you looking at the peak particle number concentration, or were you integrating like the multiple points from the coughing event?
Yeah, that's a good question. So we look at the 5 seconds, which contains the peak.
Okay.
To average them, yeah. Because as you mentioned, the cough varies. There could be 2-3 seconds to 5 seconds. So I would do a 5-second average.
Okay. From Bethany Sutherland, did you notice an increase in the background level over the course of the 5 minutes you were testing?
The increase of the background level, it's not common to see the increase. So every time before each experiment, we use a very strong HEPA purifier to clean the air, flush the room. So we make sure the concentration is within certain range.
Were the HEPA filters on during the coughing events also?
Actually, that laboratory room is a HEPA filtered room. So yes.
Oh, okay.
Yeah.
So just by virtue of the ventilation being on. Okay. From Vladimir McKeeve, I think this is a comment on limitations that the sides are really important for surgical masks, and so the directionality is a limitation. From Kaisen Lin, you mentioned that particles can shrink to smaller sizes due to evaporation. Would you expect an increase in number concentration for particles of diameter less than 0.5 micrometers?
I would not expect the increase of the particle number concentration by the size shrinking, because even though the large droplets, so some large droplets settle down on the ground, but some droplets shrink to smaller size, but they are still the original size. I don't expect they would increase the total number concentration.
From Maria King, a comment that there are no 2 identical cough events, not even from the same person. From Dale Frame, also a comment, We should be careful not to intermix the terms protection and barrier. The study herein speaks to barriers, not to protection or protective devices. And then from Nestor Roja, will you test the combination of cloth mask plus surgical mask? I guess that's in reference to a lot of recent media coverage on wearing multiple masks, so-called double masking.
Yeah, that's an interesting point. Like, we haven't tested the double masking. I think it would be definitely interesting to see this different combination of different face masks.
From Dale Freem, you measured velocities. Did you happen to capture the differential velocities between speaking and coughing? And then consider the impact of the lower velocity combined with significantly smaller aerosol size distributions as found in speaking.
Yes, like while we were measuring the velocity from coughing, we roughly test the talking and speaking as well, but it does have a huge difference, but unfortunately I don't have data to show here. Yeah, so the coughing flow rate is way higher than the talking.
Did you do any measurements instead of with coughing, with speaking, with the same measurement setup, I guess? And then was the volunteer speaking at all during that setup process of the experiment?
Okay, so first, like during the coughing test, like we like both me and the volunteer were keeping quiet during the whole process. But yeah, it's interestingly, we actually test the talking using the same protocol, but because I would say it's a very large diluted room with good ventilation, we couldn't see any difference between the speaking particles to the background, since we are only able to maintain the particles background level less than 50 micro particles per cubic centimeter. So the signal is harder to detect for talking and speaking.
From Rebecca Mirnas, APS detection limit stated was 0.5 micrometers in diameter, but submicron particles were listed as those most common in the PPE removal rooms. Do you believe that the smallest particles were adequately detected by the APS? Is there a different tool for measuring submicron particles? Wondering whether emissions from breathing would be detectable in a similar setup.
Sorry, can you please clarify the question? It was a little bit long.
Yeah, so I guess the question is really around what are the limitations of your methods for the for particles that are smaller than 0.5 micrometers in diameter, and then what are your thoughts on how best to understand the behavior of those smallest particles?
Oh, okay, I see. So yes, our study has a limitation to measure the size range less than 0.5 micrometer by just showing the size distribution. But we do measure the total particle number concentration. I would say it's mainly consisting of the smaller particles, which also provide the information for these particles.
And then finally, from Antonio Tasculu, it's very interesting that the surgical mask and the N95 mask had similar particle reduction had the volunteer been fit tested for the N95 mask. That would be in reference to the OSHA fit testing training and protocols that people who use them for occupational use would undergo.
That's a good question. We actually didn't do fit testing this study because we were trying to simulate a situation when the general public who's wearing the face covering, how bad or how much leaking it may result in. And yeah, it must be interesting to see the similar results between surgical mask and N95. I would say, as I mentioned earlier, our protection effectiveness is different from the filtration efficiency, which is mainly due to the ability of the face covering, the materials of the face covering. But our is highly dominated by the contour. But as we can see, many people wearing face mask in the street, they may not very appropriately wear the face coverings with the large lickings around their face. But what we can do at least is we can make sure our volunteer by visualizing they're wearing they're wearing the face coverings appropriately.
I would also be interested, like if to repeat the same measurement, but with the inlet, instead of having the inlet in front of the person, having the inlet right to their side, or simulating someone in a line at the store, having it right behind their head too, and seeing if the fit at the edges has different leakage for those two types.
Yeah, that's definitely worth to investigate, as because due to like we don't have that many instruments, like right now we only focus on the front direction, but yeah, for sure I think the side direction and even back there also have potential risks for the particles traveling to different locations.
I think that brings us to the end of the current questions that are in the chat. If I missed one, please let me know. And if anyone would like to unmute themselves and ask a question or make a comment, also just let me know.
Yeah, I actually want to follow up on the discussion about checkout lines and people in close proximity. So something that we've seen a lot in precautions at grocery stores, banks, and even classrooms where there isn't enough space to maintain a 6-foot gap is a physical barrier, like a sneeze guard or a plexiglass sort of a cage. So this is still part of the the latest CDC recommendations for school operation. So given that a barrier like that is similar to a face shield, which you've shown to have negligible effects on particle reduction, would you say that building and setting up those barriers is a good use of resources, assuming people are wearing some type of a cloth or surgical mask?
Sorry, are you saying the barrier in like a face shield?
Yeah.
Where like people using like supermarkets, like.
Yeah, so those clear shields that people have at like checkout lanes.
I see. I think even though we didn't test it, I simply believe we have a similar function with face shield. But even though it's not like a face mask attached to someone's face, but still, I would say it may be able to to reduce the large droplets which settle down on the surface. So, and also I also noticed like even in restaurant or like supermarkets, people were not just like having the shields, right? They also wear face masks. So I think those double protection is also, it could be effective.
And a similar scenario that goes with that is indoor dining or eating in schools. So people are obviously unmasked in those situations. But I would also think that the initial air jet velocity is much lower than when you're coughing. So in that case, would you think the physical barrier would provide some mitigation?
Let me see, because I don't have data to present, so I couldn't see how much protection it can give, but I think with barrier it should be better than nothing.